special diseases like Castleman disease, and he's been seeing a bunch of cases here at Penn and beyond. So this whole time is set up just for Q&A, but before we open it up to the audience, I don't know if you guys would want to get on the line, add anything else about your backgrounds or anything about Castleman's you'd want to share before we open it up to the crowd.
I just call it the pink zebra with purple stripes.
That's right.
I'm just really excited to be here and meet all of you. So,
I love seeing the turnout here. This is so wonderful to have everyone together.
Woo! Oh, we have some pre-submitted questions? Awesome. I was going to stay away from them. I'm just trying to keep the distance.
Can we give a shout out to the staff? What an amazing day.
There's one more pre-submitted question.
Woo!
All right, so we do have some pre-submitted questions. We'll be looking at the chat on Zoom to also bring in those questions. But to get started, I have a pre-submitted one. There are actually several about the duration of treatment. So first, how do we determine if treatment should be lifelong? For example, in asymptomatic UCD patient, how do we know when to consider stopping treatment?
So an asymptomatic UCD patient on siltuximab?
Yes.
Okay, so the decision point to start siltuximab must have been based on when they were symptomatic. So if they have been remaining asymptomatic on therapy, I don't stop treatment, but I try to wean. So I stretch the treatment from the 3-week time point, and I actually start pretty slowly. Like I will go to 4 weeks and 5 weeks and 6 weeks, and based on how they're doing from a symptom perspective, stretch from there. I will tell you that for most of my idiopathic multicentric Castleman's patients, it's been hard to taper much below every 6 weeks. So that has been a little bit of a barrier, but it's a discussion. And other people can comment as well, but sometimes it depends upon what the patient's goals are. So for example, if you have a patient who wants to get pregnant and wants to come off of therapy, there is a discussion about whether that would be reasonable to do, or if there's other reasons that they need to come off, then you can discuss that. I have had patients who have stopped siltuximab for a variety of side effect issues and have remained off therapy for some time, and that varies from as little as a couple of months to a couple of years, and that really depends on the volume of disease and where they were when they stopped.
So maybe a related question here. So what's considered out of remission? A change in labs, signs or symptoms? Maybe you can talk about what remission means and what it means to be out of remission in Castleman disease.
So the 3 different things that I use for all of my assessments would be, 1, symptoms. Do you feel bad? That would be a way of you shouldn't be able to know if you're out of remission. Second would be laboratory abnormalities, which are hopefully moving in the same direction as the symptoms in which you're feeling. And then the third, and probably the laggard of all of these, would be the growth of lymph nodes to suggest relapse disease. I think in situations where patients are seeing increases in their lab abnormalities but are still feeling okay, that would make me at a point where I'm concerned that they may start to feel a symptomatic relapse, that it could be a harbinger. If you see a long period where the labs are trending in the wrong direction, they're going up across different time points and to a degree in which we suggest that they are that they're not just small little laboratory abnormalities or any sort of periodic period of unwellness. So that's what I would typically look for, was all 3 of those things, particularly symptoms and lab abnormalities, to suggest that a therapy is no longer working and someone's no longer in remission and they're having relapse disease.
Remember that the original study for siltuximab didn't really define response the way we do in cancer studies. So for example, when I treat lymphoma, I look for complete absence of lymphadenopathy, Whereas in multicentric Castleman's, the indication for siltuximab is based on an improvement of symptoms. You may not necessarily go to zero in terms of your lymphadenopathy, but if your symptoms have resolved, that would be considered a remission.
How about some in-person questions? Anyone ready?
My question is there anything out there
Randy,
that
just, if you'll take it that way, the people
Just
on,
for the
on
virtual
video
side.
can hear.
My question is there anything out there that might shrink the lymph nodes?
We're looking.
And I guess I'd follow it up to say that so nearly all the treatments that we use for Castleman's, if they improve your symptoms, generally your lymph nodes will improve too. So if you're getting better, if you're feeling better, your lymph nodes typically should start to shrink. But of course, there are sort of stubborn lymph nodes, maybe stubborn people. I don't know, but I think that it's a good point. I mean, I think that if you want to knock out some lymph nodes, chemotherapy is going to knock out your lymph nodes, right? But the question is like, do you have to do everything possible to get the lymph nodes smaller?
The other issue with lymph nodes is that we know that a percentage of patients with Castleman's have the risk of having a different blood disorder like lymphoma or myeloma appear. So if the lymph nodes are not behaving the way that we expect with therapy, then there should be a consideration for a repeat biopsy just to make sure you're not missing something.
We have another question online regarding medication. So this person's tried siltuximab in the past to treat their IMCD. It's failed, but have found Rituxan to work really well, but it's not FDA approved. So David, maybe you can talk about how close we are to getting it approved for treatment.
So rituximab is not FDA approved for any form of Castleman disease, but it is extremely effective for HHV and associated multicentric Castleman disease, and it's somewhat effective for some patients with idiopathic multicentric and also with POEMS-associated MCD. There's no efforts that I'm aware of to try to get the label changed for rituximab. It's extremely difficult to get a disease added to the label for an approved drug, especially a drug like rituximab, which is no longer on patent. So I don't think there's any efforts to do that, but the whole premise of the work that we do with the CDCN and also with every cure is that it doesn't actually have to be approved for that disease to get paid for. And so I think from the CDCN side, we're happy to work with whoever asked that question with their doctors because there's so much evidence on rituximab for Castleman's. I mean, all three of you prescribe it all the time. And typically you don't have issues with insurance, right? Or do you have insurance? I guess you don't have to deal with insurance as much.
We don't take insurance at the NIH, so everything is free. But it's in the NCCN guidelines. So
Should be fine, right?
Your doctor's having trouble, they probably just need some education about how, or some help to figure out how to work with the insurance company to get it.
Yeah, we'll work with you, whoever that is.
So just for the audience, the NCCN is a consortium of cancer centers that put out recommendations for therapy in terms of what is first line, second line, and third line. And so usually insurance companies rely on that to provide guidance for what they will and will not cover. Now, I can't say that I'm a big fan of insurance companies, and I would really love to have Kate's situation, but you do what you have to do, and I think it's just a matter of getting the right information. Most insurance companies will respond to having the data that's presented, so part of the reason that David's been so active in publishing our findings is to have that in the medical literature so you can use it.
Totally agree.
Another question in the room?
Are there proactive therapies a patient should be on besides sirolimus?
Great question. I guess maybe I'll answer that by saying that, we've got these treatment guidelines, and generally the treatment guidelines, obviously they're dependent on the subtype of Castleman's that you have, and for most of our therapies, we do recommend continued treatment, which could be described as sort of being, proactive. But it's really important that that you, your doctor, and experts sort of discuss what the right treatment is. I don't know what you guys would add. I mean, I should mention sirolimus, that's the drug that's helping me so much, but that's not the first line sort of standard of care. First line standard of care would be IL-6 blockade. And then if that doesn't work, then you move on to other things. But I don't know what else you'd add.
Just to kind of round out the question, when you're on a maintenance therapy, it is very important to make sure that you're also covering your bases in terms of prophylaxis and prevention of infection. Unfortunately, everything that we do to protect you from the Castlemans or the effects of it can be very immunosuppressive. So when you're on therapy, generally being on antiviral therapy to prevent shingles or medications to prevent certain types of infections is very important to maintain your health during the treatment.
So following, let's go to you next in the room, but I'll ask one in between. So we had talked about tapering in the case of UCD, but this question is about tapering siltuximab. So the NIH says to use siltuximab every 3 weeks. At what point, after 100 or more infusions, can you delay to every 4 weeks? And when can you stop getting Benadryl infusions?
Wow, that's super specific.
I'm looking for dates and times.
Okay, well, I would say that given you're all pink zebras with purple stripes, the treatment has to be personalized to you. You have to establish a resolution of symptoms that's stable. You're not having any flares on the treatment. You're doing very well. You're back to your normal life. Once that happens, and that could be after 6 months, it could be after a year, then you can try stretching treatments to every 4 weeks and then from there. So there's no magic number about how many to do. I think there is a certain level of concern on the part of your treating physician that they don't want you to go backwards. And so it becomes a discussion about when you and they feel comfortable doing that stretch. With regards to Benadryl, I base it on whether or not the patient is reacting. If they are having no reactions to the siltuximab, my first step is to actually switch from Benadryl to Claritin. And then if they're not having any reactions to that, then we come off. But again, very personalized to what that patient is experiencing.
Any additions to that one?
I have a question. I'm IMCD and I'm on sirolimus, doing great, thank goodness. But my CT recently showed that I had some scattered irregular opacities, new since previous CT 2 years ago. So they sent me to a pulmonologist and he's scratching his head, like not sure if it's Castleman's related or if it's possibly a side effect of sirolimus. So just wondering if you had any thoughts on that.
I think your doctors are doing the right thing in terms of getting the appropriate evaluations, but these ground glass opacities, these GGOs that they see can happen with almost every therapy that we give. It could reflect kind of asymptomatic viral infections that you experienced. It could be your body's reaction to the sirolimus. There's a lot of factors at play, so it's hard to tell exactly what it is. And if you're not symptomatic from them, your pulmonologist is not going to recommend the next step, which would be a biopsy.
It's the the dark side of scans. You find things.
One more in the back there. And while the microphone's getting to Eric, I'll ask one more. So in the spirit of backup planning, if siltuximab is not available due to some sort of like disaster or resource availability, what's the alternative treatment to control symptoms or a flare? Is prednisone an option? This person's on a 3-week infusion rate.
Yeah, so I think for patients who don't have siltuximab available to them, we would often recommend its sister drug, tocilizumab, as another IL-6 blocker.
Prednisone, any comment on prednisone?
we typically would give some sort of steroid like prednisone in the beginning while patients are starting their therapy, and then start to wean that, assuming that they are getting good resolution of their symptoms.
I actually have one before I get to you, Erica. So, because since you mentioned tocilizumab, according to the new guidelines, toci's not listed as a drug on the protocol anymore. Why is that?
Well, our treatment guidelines through CDCN, we do list tocilizumab as an alternative. If siltuximab is not available, toci is listed as an alternative. I don't know, maybe the new NCCN guidelines left it off. I'd be surprised.
The new guidelines left it off primarily because of usage for cellular therapies. There's been
Shortage.
a shortage of toci, which is critical in the setting of cytokine release syndrome.
Got it.
But we haven't had any trouble getting it.
Okay. Erica?
I just had a question. My son, he was taken off of the Jakafi a month ago because they said he hasn't been in the hospital. He's been doing well, but he was telling them that he's not getting stronger. Like he felt like he wasn't strong, and the doctor was like, maybe it was that medicine. That I was just wondering, could that get him kind of weak, like still, because he hasn't been in the hospital since he's been out. So.
Well, that's wonderful. It's just hard to evaluate exactly why here in this setting, but some of the things that you need to think about are whether he was on other therapies that can affect myopathy, like steroids. So the combination of Jakafi and steroids can produce weakness of your muscles, and Jakafi itself can produce significant fatigue. So one of the reasons why people come off of Jakafi for diagnoses like myelofibrosis is that impact on their muscles and their overall strength. So it's probably a good idea to come off if he's not having any symptoms and give him a chance to rebuild.
Yeah, they was thinking about taking him off either the infusion, because he goes every 6 weeks now, or the medicine, but they said they reached out to you guys and they decided to just take him off of the medicine.
So he's getting both siltuximab and Jakafi? Is that?
Yeah, he was getting both.
Wow, yeah.
I think he's getting, he's not getting the subtext. I think he's getting the one with the R.
Okay. Oh, rituximab.
Yeah.
Yeah, rituximab. Got it. Interesting. Yeah, feel free to. I don't know if I remember talking to the doctor. Feel free to encourage them to reach out to us.
Okay.
Happy to talk to the doctors directly.
Okay.
And hopefully everyone knows that is an open thing for anyone in here. We talk to a lot of doctors. Just about every day I get contacted by a new doctor from somewhere in the world. So be happy for it to be one of your doctors. Feel free to always send them our direction.
I'll get one more, and then we get to Kristen while you're making your way over, Bridget. So what are the chances of Castleman disease turning into another lymphoproliferative disorder like lymphoma? Do we ever see that?
Yes, but it's rare. So the first thing to make sure is when the initial diagnosis is made in the stagings that there isn't a lymphoma hiding, which is the reason why a PET scan is recommended as part of the staging for new diagnoses of Castleman disease. If there is evidence on a CAT scan of, for example, another lymph node that looks very, very bright on the scan, that would be an indication that perhaps that lymph node would need to be biopsied to make sure that there is not a lymphoma hiding. Other than that, for particularly patients with unicentric disease who have not had their disease resected, there is a low percentage chance risk, low single-digit percentage risk of transformation of a changing to either a large cell lymphoma or this other kind of cancer called a follicular dendritic cell sarcoma. They're rare, but they certainly do occur for patients with unicentric disease who have not had their disease fully resected.
And I'll just make a comment. In multicentric Castleman disease, when we first got into this world about 10 or 12 years ago, the studies that have been published up until that point suggested a fairly high increase in the risk of lymphoma, like maybe a 2 or 3-fold increased likelihood of getting lymphoma if you have Castleman disease. What we found subsequently is that if you look back at those prior studies, there were a lot of people included in there who actually had lymphoma diagnosed before they were given a Castleman's diagnosis, and so it was sort of muddying the numbers. And if you actually look at the data from Accelerate, there's a very small percentage of people that go on to develop lymphoma that have Castleman's. It's not a 2 or 3-fold increased risk. So all that to say is there is an increased risk, but it's not nearly as high of a risk as you would have seen from earlier papers you would have read. At least that's what it appears in our experience. And Kate, that's different for HHV8 positive MCD, right? Where it is very high.
Yeah, so for HHV-associated Castleman's, it is a much higher risk of development of lymphoma, and they often are diagnosed at the same time. And so it is important when you get a diagnosis of HHV-associated Castleman's disease to make sure that there isn't lymphoma going on as well at the same time, because they tend to occur together.
The other thing is to make sure that when you have your pathology evaluated, it's at a center that sees sufficient Castleman's to be able to make the distinction, because that's unfortunately what happens many times when we get sent pathology samples, because we'll get a request to see somebody, and we're happy to see you, but we don't want people to travel until their pathology is evaluated, because if you don't have Castleman's, we're not going to be able to tell you anything differently. So I'd rather see your path first. And sometimes people will say, oh, I have Castleman's disease, but when we look at the pathology, it ends up to be lymphoma or IgG4 or one of these other diagnoses that would be treated very differently and have very different prognosis and outcome.
And the only thing I'd add to that is we were talking to someone earlier today about how they got their lymph nodes sent to, in this case, to Penn to have it reviewed ahead of time. You can also have your lymph node. In my case, my lymph node happened to be sent out to the Mayo Clinic when I was first diagnosed. So even if you can't physically, travel to Philadelphia or to Rochester or whatever, there are ways to coordinate that sending, as Sunita is saying, send your lymph node to have an expert look at it. And then, to Sunita's point, if the experts say, yeah, this really looks like Castleman's, then maybe now it feels like it's more worth your trip to go to see an expert.
I mean, Philadelphia is a great city, but the school kill's awful.
Yeah.
We've already had complaints of 76, for sure. So another question related to links within Castleman disease. So have we found anything from a genetic standpoint of, I think it's REIA? REL-A. Any connection we found?
I am aware of no connection between REL-A gene mutations and Castleman disease. There have been a few different somatic mutations that have been, some DNA changes that have been found in patients with Castleman, but I say every report I've seen has been somewhat different, and so I don't think there's been anything that has been more generalizable in terms of mutations that can account for a wider subset of patients with Castleman disease, with the exception of patients with unicentric disease. A gene mutation in the gene called PDGFR beta has been identified. In one study, they found about 40 or some odd patients with unicentric Castleman disease that they tested. They found about 17% had this particular gene mutation. That does seem like it is a functional mutation that it can cause cells to grow in the lab, so it does seem like it could be a potential mutation that can cause disease. I would say that I've also been able to find some patients who have submitted lymph nodes directly to us and been able to find the mutation in them, so I think it's a real finding, the importance of which we're still actively working on, though.
And for whoever submitted that question, we really hope you're part of Accelerate so we can get all of your records. So join if you're not. But even if you have joined and you have some sort of separate genetic report that points to that gene, send us an email so that we can look at that report with you.
More questions in the room? Kristen?
All right. So I have a really more I need an opinion. So TOSI is my third treatment. I've been on this journey for 14 years. So I have been on it for 3 years now, and I'm not doing good at all. So I would assume that at some point, I would do better. But I'm still really tired and I have terrible night sweats. So I'm should I be talking to my specialist, the CD specialist that I see, about possibly going on to sirolimus?
It's hard to tell you exactly. I'm sorry.
That's why I said more of should it just be hey, Dr. Munchie, just want to talk to you about this. want to just have a conversation about this.
Yeah, I
because-
think it's always a conversation.
Right, so-
And I do agree with you that ultimately your symptoms are what's paramount. And investigating why the TOSI is not making you feel better is pretty critical. Is it a dosing issue? Is it a frequency issue? Is it a reaction issue? All of those things need to be investigated. And although David is doing wonderfully, and we have people in this room who are doing wonderfully on sirolimus, it's not a home run.
Right.
I'd say it's between a double and a triple sometimes. So, which is great when you're a Philly, but
I haven't even hit that double yet.
yeah. So I just want to make sure that you're not thinking that sirolimus is going to automatically be that thing.
No,
and
I
just
don't
make
anticipate
sure
that.
that
Right.
you're modifying the TOSI a little bit first.
Okay. Yeah.
Because there are ways to potentially make that work better.
Like instead of doing it like in every 2 weeks, like kind of stretching them out type deal.
Yeah, I mean, if you're having reactions to the TOSI, then it may actually benefit you from a symptom perspective to stretch a little.
Okay.
If it's a matter of not responding at all to the TOSI, then potentially adding steroid back or adding other agents could potentially do it. And I have patients who go back and forth, like they've been on Siltux, they've come off, they've gone to TOSI, they're not doing well on TOSI, it's been a while since they've had Siltux, and they go back and they have a response. So, like I said, it's very individual, but I think the key is to figure out why the TOSI is not working first.
Awesome.
But definitely let Dr. Munchie know.
Yeah, I will. Hey, if you're watching right now, just so you know, I'm gonna have a conversation with you in a few months. So,
Coming your way.
thank you.
You heard me.
And I think the lesson here is our goal for every one of us should be that we achieve the state of health that we had before we were diagnosed with Castleman disease. That should be our goal. It's not going to be something that's achievable for everyone, but I have the same state of health that I had before I had Castleman disease. Gary has the same state of health that he had before Castleman. There are people in this room who are at that full state of health. That should be our goal. And if we're not there, then you should talk to your doctor. And your doctor may say, listen, like this is as good as it's going to get. And then you just say, I am so thankful to be here. But if there are ways to get closer to that state of health you had before Castleman's, then it's worth pursuing. There may not be an answer, but it's always worth pursuing.
And it's a risk-benefit analysis too. So there's some patients for whom chemotherapy was the only answer, but they had sepsis and they had all sorts of complications, neuropathy, et cetera, that they then live with after. So it's a discussion.
All right, let's go to Roland and then Gary, and then I have one more online.
Yes, kind of being not nervous, but question. I have a question. I'm one of those fortunate ones that I have both, diagnosed with both Castleman and multiple myeloma. I've been lucky enough for it. Everything else has been going straight. Till last month, I went back for my annual treatment, and my question is, I have lymph nodes that are getting larger. Trying not to panic. If this was like the start of something new, or it is something new, but I mean, should I go into the panic mode that I'm gonna have to go through the 2 stem cells, all that? Just me planning it myself. But my real question is this something that as long as you go, there's a possibility, or is this a beginning sign that I'm going back into or out of remission?
So what we've learned, and we're still learning because each one of you is a little bit different, that the disease is a waxing and waning one. And people will potentially need treatment again. And what that treatment is depends upon how much disease they're dealing with and what variant they have. So if your lymph nodes are growing but your myeloma is under control,
Yeah, I'm still in remission.
then it's time to potentially do a PET and get a biopsy. Data in this disease is especially important both for you and for the CDCN because we're learning from each one of you.
Yeah, and what it is, normally I would go annually, Now I'm going back. Dr. Van Reed, best doctor in the world to me. Okay, it's coming back in 6 months. So I'm trying to make this mental trip from now until 6 months and thinking that everything, hopefully everything go all right. But it's a man thing. Am I going through this? My final question is, how many lymph nodes do we have? I've already had 2 of them taken out, so I'm like, okay, am I get down to the the final count? Thank you.
You have hundreds, and you can actually develop new ones based on inflammation or whatever process is stimulating them. So
Okay.
I don't actually stop to count.
No, I mean, at first I was like, is that a good question to ask? But then I gotta ask it.
That's a good question. Roland, the only thing I'd add is that I know you mentioned it'll be a little while till you see Dr. Van Reed and you've got some stress. I would recommend just reaching out to the office and saying, hey, I heard about my scan. I just want to, have a sooner visit. And even if he doesn't have space, get in with someone else. UAMS is so great. Another oncologist there would be really good. But that's, again, something I would just say for the whole crew. As a patient, I can tell you I know how hard it is to wait between appointments. And if you're really concerned about something, sometimes we pick up on things that maybe aren't picked up on the scan or aren't picked up on blood work. Just advocate for yourself. And so I would recommend just reach out to his office and say, hey, can someone see me in the next couple months? That'll just make me feel better.
Yeah, and thanks. And that's what I know that I'm gonna have to do because I don't want to get into that panic mode because I've been going so long,
Yeah.
with nothing, with no glitches. And it's like, man, I get past the 10 years old and something come up, but that's life.
Congratulations.
Okay,
Yeah.
Thank you.
Yes, absolutely, Roland.
Yeah, the best news would be that you had an appointment because you were nervous, and then the appointment was all good. And so, I think that's better than you being nervous, not having the appointment, and then, wishing you'd seen someone earlier.
That's right. While we bring the microphone over to Gary in the room, we do have a question on Zoom. So this is for a Tafro patient that's just had their 5th dose of siltuximab. And they're wondering how long it will take to resolve some of the ascites, edema, and other debilitating side effects.
So fluid accumulation can unfortunately be slow in improving, except for, of course, the patients who it isn't. But generally would be a little bit slower to improve. I would usually suspect that they should be starting to have improvements by about anywhere from 6 to 8 weeks after the initiation of siltuximab, when it's working well for them.
But there's a lot of factors at play. So, for example, if you weren't in for Tafro and you weren't eating and your albumin is now 2, until you get your nutrition improved, that's not going to improve. So that's why there's variation in exactly how fast the fluid comes off.
Yeah, the only other thing I'd add is, if you're 5 doses in, so about 12 to 15 weeks from starting, you should have seen laboratory improvements by now for sure. So the laboratory changes should happen early, and some of these symptomatic changes are going to be later. But if you aren't seeing laboratory improvements by your 5th dose, and you're also not seeing symptomatic improvements by your 5th dose, your doctor, and you have Tafro syndrome, your doctor should really be considering what else should potentially be added on or replaced. But yes, if labs are improving and it's just a matter of your ascites, hold the line, hold the course. It will get better. If your albumin's back to normal, your kidney function's back to normal, and you're eating well, like that, between that trifecta, the fluid will eventually start coming off.
My question is, I think it seems to reflect a lot of people's experience, but not mine. And I was talking to David very recently about the onset of COVID, that my selfish concern early on was less that I was going to get COVID because I thought I could avoid that. But if I went into flare and I couldn't get into the Penn ICU where I've been treated at a center of excellence and my oncologist is on the scientific advisory board and I've had great care. If I have to be treated in Lehigh Valley and it's not a center of excellence, how exportable is the center of excellence? What makes something a center of excellence? How do you build one? Or failing that, how do people in a critical state of flare where you don't have a lot of time get the benefit of that?
Phone calls. It really relies on your local team to reach out. You know how easy it is to reach us. We're not difficult. So we're happy to talk to anyone and everyone. We've done it. We've done it across the world. So if you have that situation where you're, and you have a wonderful advocate sitting next to you. So I know that she will find me in the middle of the night if she needs to.
Stacy.
So it's just a matter of communication, but know that we are here. I mean, that's part of the reason we do this, is to make ourselves available and present such that you know that you can reach us. I know it's so scary, and part of it, particularly if you've had TAFRO, is the urgency of it, but we're available. You can find us. And that's what makes a local center equivalent to a center of excellence, is that communication. Sometimes they don't have the drugs, or they don't have the ability to do what we need to do, and that's when you have a helicopter.
Right. Gary, you had mentioned COVID, but more from the standpoint of, if beds are filling up. But we do have an online question that is, can COVID cause an autoimmune response and actually trigger a Castleman disease flare?
Well, as
Too soon.
as the resident patient, physician, and COVID-infected person, I guess I should handle this. So
How are you feeling, David?
I'm feeling better. Thank you for asking, Josh. I'm about 80% of where I was about a week ago, so I'm on the mend. And I showed them my Whoop data earlier for how my vital signs are improving. But we did a study that we published about 6 months ago, and actually probably most of you in this room are part of it. So anyone who's an Accelerate, but also we sent out a survey about Castleman's patients' experiences with COVID infection, COVID vaccination, and how those things were potentially associated or not associated with Castleman's flares. And what we found is that, first off, Castleman's patients, thankfully, had similar experiences with COVID infection as the healthy population, meaning that 1 out of the about 16 patients who had been infected at that stage of the pandemic, only 1 of the 16 had been hospitalized, which is on par with like the healthy general population, which is great. Because we were all worried. I don't know about you. Beginning of the pandemic, I lived under a rock with my wife and kids. We wouldn't even go outside on walks. We were like literally only in our townhouse. So, good news is it doesn't appear that Castleman's patients have clearly worse outcomes when they get infected with COVID. There are some exceptions to that. Certainly patients that are on rituximab did tend to have more severe experiences with COVID infection. That's something that's well established way outside of Castleman's. We did find a couple patients where they had relapses or they first presented with Castleman's around the time that they got COVID or around the time that they got the COVID vaccine, which is interesting because there's a correlation. But the problem is that most of us at some point over the last couple of years did get COVID at some point, and some of us would have gotten Castleman's whether or not we would have gotten COVID at some point in the last few years. And so it's really hard to tease apart whether COVID could have triggered or not triggered or been involved or not involved. There are a couple patients where it did seem to be timely, like a patient relapsed about a month after their COVID infection. That felt like there's a connection, but again, it's just hard to know because all of us are getting COVID, some of us right now, and all of us have Castleman's, and so it's hard to really tease apart, would this patient have already relapsed, whether they got it or not. Interested to hear what my colleagues think.
I just wanted to put a plug for the registry. This is the reason
why we
David
do
is able to say what he just said is because of you all shared your stories with us about COVID and Castleman disease. So we were able to add all this color in terms of the numbers or in terms of people's individual experiences surrounding COVID and their Castleman flares or the vaccine, their Castleman flares. This all came from the registry, and that's the whole point, is it allows us to use your stories and find trends and to ask the questions that we all have about this disease to the registry, to the larger experiences that you all have, to see if we can find these patterns and answer these questions that we all have about the disease.
That's right.
Love it.
And Josh is now leading the registry team. So get us that data. I know we talked a bit about spacing treatments, but have a question from Niraj over Zoom. How long can one prolong siltuximab safely in between treatments? I know it's a personal, it depends.
The longest I've gone with a patient is 6 weeks, and unfortunately, the patient couldn't tolerate 7, so we had to go back to 6. But that's as far as I've been able to get. But remember, we're not talking about large numbers. We're still in kind of an anecdote phase. But I think Fritz also said that's about as far as he's gotten. Again, I said there are some people who have been able to stop and haven't flared, but that's really dependent upon their disease.
Related question to siltuximab. What level of immunosuppression will siltuximab bring? Are there any particular infections that we should stay very alert of if you're on siltuximab?
Primarily the same infections that patients who are on lymphoma therapy get. So as I mentioned, you need to be cautious about viral infections like COVID, like shingles. If you have a concurrent therapy with steroids, then an infection called pneumocystis is particularly important to prophylax against. But those are the typical ones. As the level of immunosuppression can be measured, and so we do check things like immunoglobulin levels, meaning the amount of antibody that your body is producing, and that can give us an idea of how immunosuppressed you are.
Thank you. We have one in the back, and then we'll come to the front.
Hi. So I guess I kind of have like a multi-part question, but it's all the same thing. So I was lucky enough to be accepted into my state's health care, which is very helpful when you stay in the hospital for 5 months and you have a $2 million bill. Unfortunately, I'm not getting the approval for any out-of-state treatments. There is no liver specialist that I can see for my tafro, for my liver. There's no Castleman specialists in Maine. And I've mentioned multiple times, you can reach out to David, you can reach out to this team. When I mention Dr. David, they don't know who I'm talking about, so I know they're not reaching out. But I don't have any other options, and I'm sure there's a lot of other people that might have that problem too. My insurance will only cover in-state. So what I don't know, what should people do when it comes to that? I don't feel like, the cetuximab is working good for me, and my numbers appear to be great. My PET scan came back not looking like a Christmas tree, in my doctor's words. But I have a lot of symptoms and a lot of other things. Could they be related? Could they not? I don't know, because no one really seems to care, it seems like. I will go multiple times saying, like, I can't catch my breath, I can't catch my breath. And then they're like, okay, come in next time. And it just feels like a big pattern like that. So is there any suggestion on what you can do as a patient when you're stuck at this one specific oncologist and they're not calling you guys, they don't seem to be interested in learning much about it because they only have one patient or maybe even 2. But I'm not sure what I'm supposed to do, and maybe there's someone else out there that has the same issue. But I can't force them to send me to different specialists in our state. I can't make them give me more tests. So I'm just kind of stuck on what I should do with all these symptoms that I am having, related or not. No one knows because they're not helping advocate for me. So I don't know what to do. But is there any suggestion on what you can do in those instances?
I'm not sure about the system in Maine, but I would say that there are some rare disease networks that can potentially help you at least with coming for a consultation. And not to be political, but talking to your state representative, your local state representative may be helpful to get an exception given the rarity of your disease. I would talk to them about that. And also talking to your state Medicaid office, because if your doctor has never seen another case of Castleman's disease, you could argue that you need somebody with more experience.
Yeah, I totally agree. A couple of things I'd add. I know, Debbie, you're in Maine and you've had some really good care. I don't know if you guys see the same doctor. You guys seen this? It wouldn't work out. Okay, that's too bad.
Somebody within
Yeah, maybe it's just worth connecting with Debbie because I know that you've had a really good experience, at least with your doctors. That's one connection to make. Another is that even if your next doctor that you got referred to doesn't know anything about Castleman's, they may be more open to reaching out to us. And so actually you might just get value from like having another oncologist who doesn't know anything about Castleman's, but they might just be open. And then the third is that you've heard us talk a little about the NIH, which is this incredible very magical medical place in Silver Spring, Bethesda area, where they do provide care to Americans that need care at no cost. And so in an event where you just can't see anyone in Maine, they're not taking care of you, maybe there's a path to NIH. I don't know. I know that's not easy.
Yeah, I think it sounds like your doctor's not listening to you.
Yeah.
And yeah. Yeah. Doctors can be like that. Yeah. Yeah, I would agree with David. It sounds like you might need just a new doctor who's more willing to listen to you and more willing to reach out to people who might have more experience with the disease. And certainly NIH is definitely a place where care is free and there's lots of experts in rare diseases. So yes.
Is it possible that CDCN might be able to potentially in the future develop some patient advocacy role?
I mean, I think we do a lot of patient advocacy right now. I talk to doctors all the time. Let's see, most people in this room have talked to their doctor at some point. So we do a lot of advocacy, but the thing is, you need that person to be willing to answer a call or to make the first call. And so I think that's the challenge, is you need your doctor to be willing to be advocated to.
Can you tell me what part of Maine you're in?
I live in southern Mid-Coast Maine.
So near Portland?
Yes, I do.
Okay.
I was going to see Dr. Munchie, but unfortunately,
He's in Boston.
main care that we have decided that they didn't want to pay for anything out of state. So I get nothing.
Find me after. I might be able to give you a name.
Thank you.
Great.
So hello, I had a question about joint pain. Like I'm stable, I'm still Toxmab. I have multicentric Castleman's disease. So I'm pretty stable on my treatment and everything, but still suffer really severe joint pain to the point that some days walking is agony. I also take supplements like folate and magnesium, get lots of muscle cramps, night sweats. All of those kinds of symptoms don't seem to be alleviated. Is there anything else that we can be looking at to take or do as a supplement or different to alleviate some of those symptoms?
There's a number that you can try, but not all of them interact well with your medications, so it kind of depends upon your blood counts. So I've had some patients who've had some benefit with alpha lipoic acid, some patients who've had some benefit with curcumin, and some patients who've had some benefit with resveratrol as supplements. But each has different blood counts, so it's hard to tell you exactly what would be the right thing. I know that it's very frustrating because sometimes that's an interaction with the medication that's producing the symptoms. But if the night sweats are persistent in spite of treatment, then it may be time to think about what to do and why it's not working well enough for you. Because that's part of the symptoms that should be improving.
I was wondering if the night sweats might also be, I mean, I'm getting to that certain age, so whether that's part of the change of life and things like that as well. So,
yeah, I think it's worth a discussion with your doctor about making sure that those are taken care of. Endocrinopathies are, alterations of your hormones can run with this disease, and so it is important to kind of maintain your levels of your thyroid, of your estrogen, etc. So it's hard to know exactly what the cause is, but it is worth it to have a discussion saying, this is what I'm experiencing.
Thank you. I have 2 questions online. We do have just about 10 minutes left here. Sounds like one of the backs will get you a mic. But 2 questions regarding some laboratory values. So an IMCD patient that has lower than normal platelet counts, but inflammation, lymph node size is normal. So is there something else that could be causing a low platelet count?
Some of it depends on severity of platelet count of the low platelet counts. If it's just a little bit below the lower limit of normal, you would have more than enough platelets to heal yourself just about as well from major surgery. So I think it would really depend on the severity of the low platelet counts. In a vacuum, I would say a slightly low platelet count with all other symptoms, laboratory findings, and imaging being normal would suggest to me that it would not be a concern for an active disease process.
All right, great. And then a related question on VEGF. So is this a factor only to POEMS-related CD, or is high VEGF associated with all types of Castleman?
It's classically been defined in the context of poems, but it can be elevated in non-poems IMCD as well. It's really just a marker of inflammation. It's a signaling molecule that the body uses to tell blood vessels to be made, and it's, I would say, a very general inflammatory marker that we can see up in a lot of different conditions.
All right, we're doing good on the rapid fire up here, so I'm going to do one more, but I think it'll be quick too. So someone has been on rituximab. It's been 1 year. It works really well. How long can someone take this drug? They had heard maybe 2 or 3 years.
So we don't have a lot of data from the Castleman's population. In the lymphoma population, we generally stop maintenance at the 2-year mark, but Castleman's is a different ball of wax. So it really depends upon how well they're doing. Remember that because of its half-life, rituximab can stay in your system up to 6 months after you stop. So it is possible to stop the therapy and then restart should you have a flare.
And that's what we do in HHV8, right? Associated MCD, where you guys will often retreat people, and there's no sort of limit to where you could say, okay, I've already done it 10 times. You know, you can keep retreating, right?
Yes, you can keep retreating in HHV-associated Castleman. So we don't give maintenance therapy. You give sort of your 4 doses of rituximab and you stop.
And then if it comes back.
There are data in the, I think, other autoimmune diseases where they give anti-CD20 antibodies for even longer than 3 years. So rituximab's a pretty safe drug.
Yeah, I think it depends on the setting and how well you're tolerating. So as we discussed, immunosuppression, if you're having infections or if you're having reactions, then it's a different situation than if you're totally asymptomatic and have no other issues. But people with lupus, rheumatoid arthritis, multiple sclerosis take anti-CD20 antibodies ongoing.
And I've seen a couple people back there. I know Mr. Robbins has had his hand up for a while, so let's make sure we get to him as well.
Hi, I'm John. As a loved one and really new to your organization, if you were to commission us out of here today, what would be the best way to advocate and to make awareness for your network?
Well, first off, thank you for asking that. We said during a couple of sessions earlier today that this whole thing doesn't work without the loved ones. You guys are propping us up, you're supporting us, you're calling doctors at 2 a.m. in the morning, right? So you guys are just essential to this. So thanks for asking. I mean, I think that what you've heard is that time to diagnosis can be delayed because doctors are often not aware of it. Patients don't know to even think about it. I think helping to spread the word is a really, really good thing to do. I think that we've got a really special team here, surrounded all throughout this room of members of the CDCN, and so we're going to keep doing all the things that we can do. But I think it's helping to raise awareness. Your dad has given his samples to us. We give him a call when he gets sick to check on him, and then ask for some blood, and he always does that. And those sorts of things, that's what helps us to figure this thing out.
A couple of
What else would you
advocacy
add?
points from a political standpoint, and that's regardless of party. There are some bills that have been stalled in Congress right now with regards to telemedicine, particularly for rare diseases. So we are limited in our ability to see patients across state lines unless we're licensed. I'm sorry, I can't have a license in all 50 states. It's really awfully expensive. But if we can get that bill to pass, if it can actually come to the floor, it would allow us to do consultations for patients coming from long distances, and that would really help us share our expertise in a better manner.
Got one more. Hi, thank you. My question is around if you actually get COVID, like I did for the first time this year, and it knocked me for 6, and my hematologist prescribed Paxlovid, and I'm just wondering, what do you recommend? Ongoing. If people get COVID, do you recommend Paxlovid every time? Do you recommend no, or what do you recommend?
It depends on what they're taking. So, for example, if you're on sirolimus, Paxlovid is very difficult because you have to stop your sirolimus when you're on it. In that situation, thank heavens he doesn't need it, but David would come in for remdesivir. If you're not on sirolimus, if you're on siltuximab or rituximab, then you can actually get Paxlovid safely, depending on the other medications you're taking.
Would that be each time you get COVID if you felt really bad?
If you have by day 2 or 3 significant symptoms, you should definitely get on something to control it.
Thank you. And I have a second quick question, just as an observation for others, really, maybe. I'm years past the menopause, and the sweating came back again, the hot flushes came back again, and I was wondering, was it Castleman's? And my hematologist said, check back with your primary physician, maybe you would think about putting you on HRT blood tests, So I was put back on HRT, and just to let you know, it was a magic, the sweats and the flushes did stop. Yeah. Thank you very much for your time.
Thank you. I know that there are more questions, but we'll close this session now and move into our breakout sessions for coping with Castleman disease. So thank you to our panel, first and foremost. And thank you all for your wonderful questions. For those of you virtually that we didn't get to your questions, we've written them down, and we'll be reaching back out. But our breakout sessions are going to go from 2:40 to 3:30. Patients are in this room, and loved ones are in the drafting room with Maleva. So make your way to your next session.
Thank you.